Our next speaker is Dr. Anna Wawrowski from Vienna. Anna informed me beforehand that she is a medical doctor and a health economist, and I felt there's a sort of a bit of a dichotomy going on there. But she's going to talk to us this afternoon on the economic burden of chronic pain in the working population.
Switch it off. Thank you very much, dear chairs, ladies and gentlemen. It's a very uncomfortable place that I'm in between the coffee break and you, but I will try and do my best to make the next 10 minutes as interesting as I possibly can for you. So whenever health economists try to estimate the burden of a disease, we look at the perspective of our analysis as it determines which costs we will take into account. And there are three broad categories that we can choose from. The first one is the perspective of the patient. The second one is the payer's perspective. So in the payer's perspective, we only take costs into account that are paid for by, for instance, the sickness funds. And the third and broadest perspective is the societal perspective, and this is the one that I'm going to consider in my talk today. Furthermore, we distinguish between three different categories of costs. And let me go through them with you, and then I have also brought some examples from the area of pain for you. So you see that the first one are direct costs. There are direct medical costs, costs related to the diagnosis of a disease, but also, of course, the treatment, surgery, for instance, and direct non-medical costs, which are costs that accrue because of the disease, but are not medical, for instance, the transportation to and from the hospital. But health economists are not only interested in the grand total and in the sum of costs, but more often what interests us is how costs differ by patient characteristics or before and after interventions. And one example that I brought for you is direct costs as a function of pain score. So you see the average number of visits per patient, and you see the pain score on the x-axis. And the higher the pain score, the higher the direct costs. But what we can also see is that by reducing pain, there is also a potential to reduce direct costs. The second large cost category are the indirect costs. These are losses or gains in productivity due to morbidity and mortality of the disease that we look at. And the indirect cost category tries to estimate the impact a disease has on the workplace. If we look at labor force participation at a given point in time in general, we see that 65% in the general population without pain participate in the labor market. This percentage is reduced if we look at a population that is in pain to 55%, and in a population with severe pain, not even every other patient is able to participate in the labor market. So the impact of pain on labor force participation is nothing less than dramatic. Looking at the impact of pain relief on sickness absence, which is another classical parameter of indirect costs and productivity losses, it becomes clear that the greater the pain relief is compared to baseline, the better the patient's workability. So undertreating pain, and not only untreating pain, but also undertreating pain, is associated with significant costs. So we looked at overall labor force participation, we looked at sickness absence. Let's look at productivity at the workplace, because we do not only measure absenteeism, the time that the person cannot spend at the workplace, but also, and this is a relatively new concept, we look at presenteeism. Presenteeism means that the patient is present at work, but he or she is in so much pain that they cannot perform the usual tasks. And this is an example to show you that absenteeism and presenteeism are often measured simultaneously in the context of a randomized clinical trial. And they have become new standards when evaluating the effectiveness of interventions for our patients suffering from pain. And workability as such is slowly but surely becoming an important clinical endpoint. And what this shows me, and this is what Liam mentioned earlier, is that medicine and health economics have come a whole lot closer in our endeavor to estimate A, the burden of disease, but B, also the effectiveness of our interventions and the evaluation of different options for our patients. So we measure direct costs and indirect costs over the period of all resource use and of the greatest health effects. This is not as straightforward as it may sound, but before I come to that, let me mention the third category of costs. The third category is called intangible costs, and it's the loss of quality of life, pain, and other aspects that are very, very hard to attach a monetary value to. But nevertheless, it is important that we continue to consider and continue to evaluate the intangible costs, as they are central to the lives of our patients. And perhaps not surprisingly, the utility gain associated with pain relief is directly correlated to the percentage of pain relief over baseline, which goes to show that the amount of pain relief perceived does make a difference, and it's not just pain relief per se that is important to the patient. Let's take a moment and look at the different parameters that go into health economic analysis. And I'll just bring them up for you, and you will see that they are manifold, and you need a multitude of experts from different fields, different skills, to properly conduct a health economic analysis. So this is not done in isolation, and if it is, there are probably important aspects that have been overlooked in the analysis. And health economic analyses are clearly done with the goal of informing a policy decision. So one can only imagine that better data will lead to more informed decisions. Let me conclude by coming back to my earlier remark about the assessment of resource use over the period of the greatest health effects. Maybe we need to change our thinking and introduce decision makers to the concept of upstream investment to prevent downstream cost. And what I mean by that is perfectly summarized in this picture of a river. Suppose a person falls into the river very, very close to the well. It's probably easy and cheap to save this person just by extending a hand. If it happens later on, you will need special equipment, it will not be as easy, and it will also be more expensive. And if a person falls into the water close to where the river flows into the ocean, you will need a helicopter and very, very expensive emergency procedures to save him or her. So let's not forget about the aspect of timing and structural challenges when we discuss about the importance of adequate pain relief. Waiting times and delays to adequate pain relief are also bearing substantial costs, but also providing an adequate number of specialized pain centers is something that we should be discussing when we consider effective strategies to treat our patients suffering from chronic pain. Thank you very much for your attention.